Thank you so much. So come on, guys, let's join and have the discussion that folks have been waiting for. Hi. Thank you. How are you? Very good. Thank you. So much better now that you're here. Thank you so much. Please have a seat. And I'm likely going to have a seat as well. I hope AV team doesn't get mad at me for switching your mics. Hey guys. Hello. It's all men, which is important. I'd like to start with a self-introduction. I could talk about you, but I won't because I won't do as good of a job as you will. So why don't we start with Dr. Ali, and then we'll work our way up here.
Hi, Ali Kazayzadeh. I'm internist, co-founder and chief medical officer of a company called Seek.org. We do virtual telemedicine in 35 states.
Thank you so much for joining us, Dr. Ali. Everybody, for Dr. Ali. Thank you so much.
Hello, I'm Kevin Grundy. I'm CEO of Opsis Health, and I've been working this company for about 3.5 years, and what we do is we make it incredibly fast and easy for anyone to track their health with just a few seconds per meal.
Incredible. Thank you so much. Thank you so much, Kevin. Thank you. Incredible.
Hi there, my name is Fred Dillon. I head up the advisory services team at Hope Lab, which is a nonprofit operating foundation and a social innovation lab that develops technologies to improve health and well-being for adolescents and young adults, especially in the mental health space.
Wonderful. Thank you so much for joining us.
Great. Hi, I'm Andy Atwell. I'm actually filling in for Chris O'Brien, our CEO, who had to leave on short notice. But I'm the VP of Partnerships and Innovations at AdhereTech, and we're a digital health company that's focused on driving patient behaviors around medication adherence.
Wonderful. Thank you so much. So important things to talk about today. So today's panel is called, it has a very long name, but what it is really, it's about virtual health today and tomorrow. And we have some incredible folks here today. So I want you to get your questions ready as we discuss, and I will make sure to have some time to allow you to ask questions because it will be incredibly selfish of me to take that role only. Notwithstanding, I'd like to first talk about COVID and what that means to your business and how it might have been a catalyst for your business, because we know that COVID leveled the playing field, didn't it? It did. I see so many heads shaking. Yes, it really did, because you were one, as a startup, you were one with a Fortune 500 organization facing the same problem and needing to come up with some solutions. So Dr. Ali, what did COVID do for you and Seek.org?
Seek.org would not exist before COVID. We were a different company. We were like a technology. The name of the company was Curogram, like Instagram, and it's a cure. And if somebody doesn't know what it is, say if you know what is Instagram, probably it's something in medicine and cure. So, and everybody was telling people like, what's the name? Say, how do you spell it, right? So technically, it was a HIPAA secure communication platform. But when in technology and when COVID happened, we pivot to become a service instead of technology. So we started seeing patient telemedicine-wise. So I own urgent care in Newport Beach, California. The volume of the patient I was seeing was 30 patients a day. So it's 1,000 patients a month. So because of COVID, telemedicine got approved by insurance company to be reimbursed. So the volume of a patient went from 1,000 a month to 2,000 patients a day.
Amazing.
And yeah, so
that's amazing. So Dr. Ali and Seek.org, so at Seek.org was born as a result of COVID.
Correct.
So Kevin, how did your organization be impacted?
Well, that's an interesting question, and as I sat here listening to my colleague, I thought, well, it didn't directly impact us except for this. We are so good at tracking the macronutrients of food, we asked ourselves, well, what are those things that would help COVID pass quickly and with less effects? And of course, if you've been reading anything about vitamin D, there's a high correlation between your ingestion of vitamin D. But people don't know. How do you know how much vitamin D you're ingesting? So what we thought is eventually, not now, because COVID's somewhat past, is when the next wave comes, whether it be COVID or anything else, through the ability to track what you're eating, we do think will provide much better information for people to decide if indeed vitamin D or whatever else is necessary, you can get on top of it.
Excellent, thank you. So information seems to be vital.
Yes, absolutely. Is the lack of information, and we don't really want to tell you what's important. We just want to give you the data, right? That's the importance we don't know, but we do know that if we can tell you what you were eating, down to about 175 macronutrients, then there's plenty of other resources to help you navigate that.
Incredible. Yeah,
Yeah, for us at Hope Lab, I mean, clearly already there was a massive crisis in terms of mental health for adolescents and young adults around the country, everything from loneliness, depression, anxiety, and the pandemic just exacerbated that. The good news is that so many companies came forward to come up with virtual solutions that kids could plug into and learn more. But it did cause us to have to pivot on a number of fronts. We had worked with a company called Grit Digital Health to create a tool that allowed college students to better socially connect. There's a big crisis of loneliness in college students, and what could we do? And we were encouraging young people to get out there and connect with others like them through social challenges and being compassionate to themselves when those didn't work out. But we had to pivot when it moved all online. It was no longer in-person contact that they would have. They would have to do that through intermediated through digital means, and really finding creative ways for youth to connect and use social media in positive ways to really help them connect with people.
you know, I
they
know
care
many in this room are wanting you to expand a little bit more on your campus youth and mental health strategies and how you've deployed them.
Sure. So we, Grit Digital Health sells Nod into universities, and universities can then add it and so many of universities unfortunately have such high volumes of wait times for psychologists and therapists and all of that. So we want to introduce tools that help young people meet them where they're at, where they already are meeting and using tools. And the tools, again, really help to encourage young people to try to reach out and build those social bonds with each other as a means of supporting their mental health. We know connection is critical to that, and really making sure that connection still happened during the pandemic was absolutely essential.
Amazing, amazing. Thank you so much for elaborating on that, something that's near and dear to my heart. So adherence and COVID.
Yes. So
going
we
on
too
there?
saw a change in how our services have been leveraged. So we've been in market since 2017. We leverage a smart, connected pill bottle to monitor individuals' regular taking of their medications and if they're following therapy. And then we back that up with a live call center of an engagement team that can reach out and support those people. So during COVID, the obvious healthcare infrastructure was put under a tremendous amount of stress. And so our program was able to monitor people in their homes and know whether they were staying on therapy or not, and then be able to reach out to them over the telephone so that we could interact with folks prior to prescriptions needing to be refilled or coming into the pharmacy, or prior to following up with physician visits. And so by being able to reach out and communicate through text message or phone calls, we were able to relieve some of those stresses on clinical programs by managing it with our own solutions. Wow. And in addition to that, I'll mention one more thing is the clinical trials space. So the companies were still very focused on making new molecules and bringing them to market, and it allowed for decentralized clinical trials. So now you no longer needed people to come in to get their medication or come in to check in with those doing that research. They were able to gather that data from patients just from their home by using the connected product.
Wow, you know, the NIH was here at the Health 2.0 conference day one. I'm aware that they've left already yesterday to get back to the important federal work they're doing. With that said, there was a question that was posed day one. How do we orchestrate all of these efforts and initiatives that are exerted by American entrepreneurs and innovators and movers and shakers so that we have a concert of sorts versus various solo acts that when united, we could actually make a much more tremendous impact than us alone. So Dr. Ali, I know based on what Andy said about text messaging and making things more convenient to access, I think you've done a really interesting job at innovating access. Can you tell us a little bit about that?
Sure. Before COVID, I was doing zero telemedicine. Right now, it's over 80% of my practice is telemedicine.
Sorry, doctor, what were you doing before?
Urgent care, primary
care.
care, but because telemedicine wasn't reimbursement, and it wasn't people behavior, and it wasn't doctors' behavior, even we had the platform, and we wanted to give it for free to physicians, even a young physician, they didn't want to use it. One, because insurance company not paying for it. Two, because infrastructure wasn't there, and it wasn't people behavior, right? COVID changed that overnight. And because of that, we started actually learning a lot more about people, about my patient's home situation. So what we learned was, completely different from the experience we had beforehand.
So Kevin, I know that COVID, you said, didn't necessarily impact your business. Because nutrition is nutrition, no matter what pandemic, what war, what human-caused calamity might be going on. But how have you kind of communicated this idea of communication, this idea of expanding access to the folks that you serve in something as important as nutrition? Has COVID revolutionized or innovated any of those as it has in mental health, which we'll get to?
So we're pre-launch, so it's a little tough question to answer. But the earlier question that I wanted to dig into very quickly, which is how do you take an assembly of startups and get them all to be going in the same direction? Okay, and to be honest, I worked for Steve Jobs for 7 years, and one of the things he taught me was you can't go to a customer and say, "What do you need?" And you can do that, but they have a limited view on what's possible. So what I've learned and what we're doing in the company is we imagine what should happen, and then we put together the solution. Now, it's generally speaking, if you're going to be successful, it's got to be something very new and very different. So I'll ask you all, do you know the Apple App Store? Right? Before the iPhone, there wasn't this thing called an Apple App Store. But now the whole world has access to a platform that pulls it all together, and you have hundreds, if not thousands, of companies putting things into the App Store. But it took that one, crystallization of a new way of doing things, and that's the way we view what we're doing, was we're making that platform for collecting nutrition information.
So is this kind of like an aggregation of sorts? Is that where you're going with this? Because that's what I see the Apple Store as, an aggregation of...
Well, it's an ecosystem by which...
Ecosystem.
Yes, that people know how to interface with it, develop to it, monetize it, And it's a big pull, right? It's not like you just make one app and be on your way. You have to make a platform, you have to advertise it, you have to put APIs out. And I think that's what it's going to take to get a lot of these new things, and there's a whole lot of them.
Yeah.
But right now, they're all developing in verticals, right? I have my API, your API. And so our major goal is to find a way, at least on the nutrition side, to homogenize it all.
Thank you. So just as and I'm not a technical person, API is,
It's an application primary interface.
and it's something technology people know about. Google it. At this point in time, it's the latest thing behind integrations. I'm a healthcare person. Proudly so.
Okay, yeah, I'd like to add something to that,
Please.
actually. I think, one of the things we've been really focused on as an industry is interoperability. There's a long history in healthcare of siloing of data. It's very hard to get folks to share that data, but the companies themselves are taking advantage of technology and the use of APIs. A lot of technology that used to be very proprietary is now built sort of modularly with the ability to use APIs to share that information between organizations. And so we operate that way, and I assume many of my colleagues here do that as well. And then there are other companies that specialize in sort of being that universal adapter for APIs so that more data can be shared. And so the more that you bring together and able to correlate with that information, the more powerful the outcome is. So
Absolutely.
I really, that technological advance that certainly didn't start in healthcare has been a big benefit to how we're able to leverage the data now.
And we're still striving, a nice way to say, to get there, because there are regulations on the, well, that have not yet been rolled out, and this is not a regulatory discussions. I love those. But this isn't one of those. But I want to hear about reimbursement as it relates to Fred's initiatives in behavioral health.
Yeah, certainly. We're a mission investor, so there's several companies we're helping to support, including Equip, which was mentioned the other day around eating disorders, as well as Hazel Health, which does teletherapy in schools and has gotten to 200 million kids around the country. And so it's really important that we work up models where Medicaid and other reimbursers will pay for these services. And we're increasingly finding ways to prove out that there are cost savings, there are ways to do this virtual care that can really move the needle. And the pandemic did help bring that to life and really helped open the eyes of many to see. And so we're having good efforts. There's another company we support called MindRight, which does digital coaching for young people and has gotten into the Medicaid program in Washington, D.C., and has found ways to get their coaches reimbursed and paid for through Medicaid. So I think those innovations and really pushing forward to find ways, I think this is where science comes in. We need rigorous research of these interventions to prove that they work, and then really proving out the return on investment ultimately to get the funders to be able to pay for this. And a lot of the times the employers are leading the way. Employers are looking for ways that their employees can get these benefits. So that's also a way to go to start out, try to get employers to pay for this, and then you can work on the commercial sector and then on the public sector as well. But I think the public sector is so critical, especially with the equity issues that we're facing. Needing to get more care to people who have been historically underserved and historically have to be resilient. We want to give them tools that they can now use that are available to others of us as well.
Thanks so much. I mean, really, what I really like is that CMS 1500 waivers that you just pointed out, that every state has its own program shaping the future of virtual health. And Dr. Ali, the future of virtual health, as you see it, you're really leading the way at sick.org around reaching the patient in a way that's more hybrid than just virtual only. And you're one of the few physicians that I've heard talking positively about artificial intelligence kind of taking a key role versus a augmentary role, or kind of like an ancillary or a decision support role. So I'd like to introduce that. I'd like to introduce your idea to this panel and kind of see where everybody else stands on artificial intelligence as it pertains to virtual healthcare delivery today and tomorrow?
Sure. It's come down to who owns your health data. So what's your name? So who owns your health information? You should own it, right? But you're the only one have no access to it, right? So is the reason you don't have access to it is all of these electronic medical record, the way they designed them. They designed them not to talk to each other. They designed them, you have hard time to have access to them, right? So the future of the healthcare is going to be you as a patient own your health information. It's going to be a cloud-based blockchain technology. You have ID and password, and when you go to the physician or doctor's office or hospital, you give them permission to log into your information. They can add more information to it, right? So the fact that when you go to the ER and the ER doctors wanted to do the EKG and compare your EKG with your old one and ask you, do you have an old EKG? Yeah, I do have it. But that's a doctor's office. The problem is they cannot compare it because doctor's office is closed midnight. By the time they return back to the ER doctor, you're dead. But don't worry, your health information is secure at the EMR at doctor's office, but make no sense, right? And you have no picture of your old EKG, but you have picture of everything else. You have picture of the food that you ate like 2 years ago, but you don't have picture of your blood work or EKG or anything like that. So one thing is the access need to be, instead of doctor-centric, need to be patient-centric. And two, something like this, Apple Watch, right, can monitor all of your vital sign, including temperature, heart rate, oxygen saturation, electrolytes, sodium, potassium, sugar, cholesterol. The technologies already exist. It's not just commercial as yet, but soon enough it's going to be there, right? And it's going to communicate with you, hey, you're dehydrated. You need to, drink some water. Hey, your sugar is high. Just avoid that cake that you ate like a few hours ago, right? So things like that. So I guess the silver lining of the whole thing is people are more health savvy. Their understanding of upper respiratory infection is much better. They put masks. If somebody cough, they pay attention. And also access to the information is going to be a patient-centric instead of that. And
access to information.
Yeah.
So Andy, what does access mean in adherence
So,
in the virtual context,
right,
in terms of the future?
anything else?
I think I'll leave you to that.
No, I think that's great context. People talked a lot about this, fire hose of data that is becoming more and more available as things are being able to collect through wearables, through Apple Watches, through heart rate monitors that people can wear that are like a patch or what have you. And I think one of the challenges when you talk to physicians in clinical practice or you talk to care provider organizations, they have their priority activities, and those are caring for patients, seeing patients. They don't get a lot of time to sit and crunch data or to find the better meaning of it. I've been quite surprised in some conversations I've had with some of the payers that they have not done a lot of financial analysis into how to refine things. And so I think a lot of it boils down to not just the data, but actionable information. So I think a lot of the value can come from vendors and organizations to say, what is the important parts of this data stream that we're seeing, and how can we relay that so that it becomes supportive of those that are providing care. Now, I'm not talking about AI doctors that are making diagnoses for people, but it certainly can streamline the process and make it more effective for folks. So going forward, I think there's a tremendous amount of activity that can go to improving how the data is managed as it comes in, and then what it becomes as a value-adding product or service to those that are administrating healthcare.
Absolutely. I mean, but what your answer makes me think about Kevin. And Kevin, how you're thinking about, as you're, about to launch, how you're thinking about actionable real-time, perhaps even data, informing your nutrition program platform, so to speak, before I go into mental health.
Sure. So the term adherence is big in our company, which is how do you get people to actually track their food? Because the traditional or the status quo is open up your app, henpeck your way a few minutes into a meal, and then no one wants to do that after day 2. And we look at the overall health of a human in 4 areas. It's your medical interaction with your primary care, it's your exercise, it's your pharmaceuticals, and then your nutrition. Out of those 4, the hardest one to actually track anything is nutrition, because, man, it comes and goes pretty quickly. If you got something between you and your lunch, it loses, right? And so what we do for adherence is to make sure we don't get in between you and your lunch or your dinner, but by about 4 seconds. We just grab the data and we take it off. And then we collect it over 30 days. And because we use machine learning, they're not bots, but we machine learn you. And that may sound a little stark, but it's better than you henpecking all the time. And we just say, give us 4 seconds a meal in 30 days, and then we're on it, right? We know what you're doing, and then you have your own nutrition record that you own, you dispense, and you manage. So that's how we get adherence, is not to get in between you and what you're doing.
I like this. So, but sometimes the you and what you're doing might not be the exact thing that, some doctor somewhere says it should be, especially in mental health, when you can't really measure things in a beaker or have nutritional facts to add up. How are you looking at the future of virtual health in mental health in the context of what we're talking about? I want us to keep that virtual element and keep saying virtual as much as possible.
Absolutely. I mean, engagement obviously is critical. People talked about it earlier, that without engagement, without your users first discovering it and then finding it really useful in their day-to-day lives. And this is where co-creation becomes so essential, making sure that you're creating these products with the folks at the table who are going to benefit from your solutions, and having them really go through the design carefully. We recently worked with a company called the Rescue Agency to create a vaping cessation product called Quit the Hit. And it's on Instagram with virtual coaches who guide a group of young people, 15 of them, through quitting vaping.
Could you repeat the name of this program?
Yeah, it's called
slowly?
Quit the Hit.
Quit the Hit.
And it's all about helping teens. Vaping was at huge levels right before the pandemic. Luckily, it dropped some, but there's still a big need to help kids who want to get off vaping stop. And using Instagram, which is a place that youth already are, they're used to it, finding ways that these messages can pop into their feed as they're going about their day, and they can feel supported, we've found to be really incredibly effective. So I think finding ways to insert into the daily lives of your users that can really help nudge them along in their journey is a really powerful way of helping to enhance their mental health and affect behavior change.
Health 2.0 team. Hi, love you. Can we change the name of this panel to how Instagram impacts healthcare? Because I hear Curagram, I heard Instagram reaching people where they are, in essence, is what I'm hearing. And isn't adherence about that? What do you think, Andy, about the role of social media in the work that you do in virtual health?
I feel it is a very important way to reach certain age groups for influencing. For our business specifically, though, we have tried to keep the friction to adoption as low as possible.
Can you explain what that means? Friction to adoption sounds very scientific.
Yeah. So I'll make it a kind of a simple example, and I don't mean to, do too much of a
Are you about to Instagram?
of a plug here,
Oh, okay.
but
Wow.
when we designed our product, we didn't want you to have to open an app, use a smartphone, connect with it at Bluetooth or anything like that. It operates like a cell phone. You just put your medicine in it, and it reminds you to take it, and it sends that information to the cloud. And so for us, while realizing certainly the power of spreading information through the social networks and things like that, we realized that to get the greatest amount of adherence, it needed to work into people's regular lives.
Andy, can I see that?
Yeah, absolutely. We serve a market of a lot of oncology patients that are taking chemotherapy, and there's a cognitive loss sometimes. And so having to ask someone to navigate through an app can be a bit more challenging for them, or a geriatric population. And so, thank you. So we intended to make it as a sort of transparent as possible. It's going to make sound in a second too, but it uses light and sound to get people's attention to take their medication. It detects when the bottle is open. You can hear it. And then if you don't take your medication, you'll actually get a call from our support system to reach out to remind you to take your medication. If you remember and you take it on time, then it doesn't go through this escalation process because we're concerned about alert fatigue and we don't want to overwhelm people.
This is what I really find fascinating, is how people have innovated physical reach, whether it's a product, whether it's getting kits to people's homes, during a time where social distancing and virtual is all the hype. I know that at least one other panelist here has really done an interesting job at integrating an Uber for healthcare of sorts to get you the test that you need right away. Dr. Ali, can you tell us about some of your products?
Sure. So what we taught during the COVID was we don't want people to leave their home. So we came up with a DoorDash model. If you're sick or you think you're sick and we don't want you to leave your home, we send the test kit, either rapid or PCR, to your home. And we thought how DoorDash can deliver a sandwich cost $10 for $5 or $6 to you. So if the service, I get paid like $100 or more, can I do the same thing and use the DoorDash and send the test to your home? So yes, so we did that, and we were able to do a lot of test delivery to your home. And end of the day, I was happy that I was able to save few lives, and that's what we did. And I guess you're holding those tests.
I am, and they're mine. But Dr. Ali, would you show how these work now that we've done the product demonstration?
So this is how the system works. So you go to sick.org or sick app, and you request to be tested for PCR or rapid. We have our own driver, and they can deliver this test to you. Again, every service we provide is free. We don't charge anything. We just charge your insurance. If you have insurance, if you accept your insurance, we charge your insurance. If you don't accept your insurance, we charge it out of the network. If you don't have insurance and government pay for it, we do it. If you have done insurance and government doesn't pay for it, like, we still see you for free. So we request for PCR, this sent to you, a driver come and drop it to your home, and then you grab it, you return it, there's a barcode, you scan it, you go to the virtual waiting area, and virtual MA see you for a few minutes, ask you a few questions. What are the symptoms you have? What are the other medical problem you have? Any exposed to other people? And we grab basic information. We put you in a virtual exam room, and in virtual exam, is a virtual physician see you in 10-15 minutes. And that's for PCR. Teach you how to do it, and you do it, and then you put this kit next to your door. Another drive come in 1 or 2 hours, grab it, take it to the lab, and you get the result 100% of the time in 24 hours through text communication.
Dr. I'm sorry.
And for the rapid, we just drop the rapid to your home, and you scan it, same procedure, and we stay with you for 10 minutes until we see the result. We send you the result, whatever you want to do with the result. You can do it for traveling or anything else. But for us was point of care transfer from doctor's office to people home, one thing. The second thing was our bedside manner, which, when I see you at my office is a bedside manner, but when I take care of you, virtually, I have to make sure I have the FaceTime manner instead of like a, bedside manner. So it's something that we're learning, and we're actually teaching to our provider to follow the procedure. Look at the patient, your lighting is good, make sure you look at the camera, you keep communicating with the patient. So, it's a learning process. But we're learning a lot when we do all sorts of stuff.
Well, thank you so much. So just really briefly, this is something that folks now need. If I'm traveling abroad as a U.S. citizen, how would you get me the tests I need to come back to my country?
So we asked you a question. What's the reason you want the test when you request the test? If you said traveling, I'm going to Europe. So we send you one PCR in order to get there, and we send you at the same time a rapid test in order to come back to United States. And a day before you come back to United States, you can get online with one of our same procedure, one of our clinician. We stay with you for 10 minutes until we see the result. We send you the report, electronically through text communication, PDF format. You just go to the airport, show it to them, and you come back to United States. So that was the idea we had, and we came with that, and it was working great.
Thank you so much. I'd like to switch gears to business models in virtual health. And Kevin, Fred, sorry, I want to talk to Fred because mental health is top of mind nowadays. What business models are you working with in virtual behavioral health, and what challenges are you foreseeing now?
Yeah, the big challenges are one, like figuring out what a person's diagnosis is up front, assessing them, and getting them to the right layer of care, and having tools, hopefully, that for those with less acute, you can get them to the right folks or to even applications or other things that can provide them. And the important thing is really for us is around tailoring our approaches to the people who need them. We're working on a product right now called IMI guide, which is for LGBTQ youth. And it's all about giving them a sense of affirming their identity and giving them a sense that they can actually deal with some of the stressors that come up from living in a world that doesn't always affirm who and what they are. For that one, we've partnered with the CenterLink, which is the umbrella organization for all the LGBTQ centers around the country. And this is more of a mission model. In this one, we'll be giving this product out for free through those centers and through high schools and a host of others where kids can actually get this kind of information and get coping skills. So that's for the less acute, but kids who still need this support. And we want to give them tools that they can access at any time. For those with more severe mental illness or mental health issues, you want to make sure they're linked to a therapist, and hopefully a really culturally conscious and competent therapist. So there's several companies we're working with that have business models. Hurdle Health is one that is working to provide culturally competent care to people where they can get virtual care therapy online with providers who really understand their lived experience. And that's really critical, that we make sure the lived experience is built in and understood by the providers and the companies who are providing these services.
Thank you. So Kevin, how do you think about business models in what you were about to launch in the nutrition world?
Great question. We have two entities. We have Opsis Health, Inc., which is the technology platform, and we have the Global Nutrition Project, which is the not-for-profit entity that is the repository of what we like to say is the analog to the human genome, because nutrition hasn't been mapped. And so what our business does is we offer a freemium model where everybody can just take 4 seconds and get information about what they're eating. That goes over to the Global Nutrition project where it becomes the repository for researchers and people that want to actually go figure out how nutrition really works across the world. And then we, as Opsis, we make money by providing services through ACOs that want to provide their subscribers, their clients, with actual, what I would call tracked nutrition, well-care services.
Wow, so value-based alignment.
I mean, if I want to add something to what Kevin said, you are what you eat. What you eat affects your chromosome, affect your gene, affect your family, affect your next generation, and that's extremely important. I guess we as a physician, primary care physician, we don't value that and we don't advertise that enough. I guess the education system need to be changed somehow, that we can teach people how to eat, how much to eat, what to eat, and what to avoid.
Doctor, so I would expect my doctor to tell me all the things you said that they don't focus on. Can you tell us why?
I mean, if I do that, I lose you as a patient, right? The whole healthcare system is based on sick care and sick visit, right? If I help you to stay healthy, I won't have a job. I guess the reimbursement need to change from pay for visit to pay for performance. If I have 1,000 patients, somebody need to calculate everybody's cholesterol at the beginning of the year and somebody's cholesterol at the end of the year. So if I do a better job, I need to get paid more. If I don't do a better job, so I need to be penalized for that.
So imagine at the end of 30 days and you go visit your doctor and you say, hey, I'm on Opsis. I'm going to give you a copy of the last 30 days of my nutrition manifest. And I don't really care what's in it, but I know I'm tracking it. And your doctor can immediately go look at your manifest and say, dude or dudette, you don't have enough potassium, and that's what's causing your problem. That's our vision for where we're heading.
And I think understanding the incentive structures of your buyers, I mean, in the example of Nod that we're selling into schools, we really wanted to understand what is driving their decisions to buy these kind of tools. And really, they're interested in what's going to keep more students engaged in school, more likely to graduate. So if you can draw the line to a really critical business need from your product and how your product is going to achieve that and really connect those dots, that's what can really make the difference in getting these kind of models paid for. In some cases, some of the things we're working on are more public health and population health-wise, and those we need to really look to states and other buyers like those for public health interventions like Quit the Hit that I talked about earlier. What public health emergencies are folks willing to spend dollars on at the state level to get more kids to stop vaping, to help promote their mental health in a variety of ways?
Yeah, I would like to say, so our business model, make clear that the service is free to the patient. So they get the bottle, they get the support of our team, and we've adopted a B to B to C business model. And so we aim our business to the stakeholders that have the most skin in the game, really, for that patient being adherent with their medication. And so typically, our customers have either been the drug companies themselves that know that to get maximum efficacy for their product, they need adherence from their patient. And then the second is the provider and payer groups. So it may be now a generic cardiac drug where there's not a lot of money in the molecule, but a heart attack or a stroke is very expensive. So if you're that organization that doesn't want to pay for that hospitalization or an escalation to a chronic disease, you're going to be interested in doing what you can to keep that patient adherent to their therapies, and you get the maximum efficacious performance from the medications they're on.
Incredible.
So think about it, future. If I have, as a primary care physician, if I have access to all of your, online activity, like your Netflix information, your social media, your search engine, everything happen in your social life. If I have access to all of your health information from the beginning of the your life, if I have access to the big data and convert them to small data and use some sort of artificial intelligence in intelligence augmentation. I can predict what's the chance of you having depression in 5 years. I can predict what's the chance of your heart attack, at what age you will have a heart attack, and I can predict at what age you will die. So if I have access to all of those information, and if people learn how to donate their data, NIH doing that right now, and I'm donating my data through NIH. So if I have access to all of those information, I can have a healthier community down the road.
Incredible. Healthy communities are happy communities. And isn't that what we're all striving for? Right? When you ask a parent, what do you want for your child? They might say a number of things, but ultimately happiness. And happiness now to the audience. I know that there have been a few questions here lined up. I'd like to open for Q&A. Yes, please, my dear sir.
You know, we spoke, actually you spoke about who owns the data, but that digital virtual health effort actually shines the light on the patient at areas that were obscure to the physician and the scientist. So what I would like to see is that actually this data is available for publications and for studying, for scientific examination. And there is a lot that can be learned about that. Now, we are about to head for a clinical study of COPD. And we would like to learn how a COPD patient actually lives his situation at home, and how we can manage these volunteers the best way to extract the best science. So I'm just throwing that.
Thank you so much. Madam Nakarimas. Doctor, would you like to?
Privacy and security is not exist. It's only in your head, right? Part of your health information in the United States sold 3 times a day by states, by pharmaceutical company, by pharmacies, by insurance reps to each other. And in order to get to that point, we need to transfer the ownership of the health information to people, and people need to be willing to share that information and donate that information to a lot of other people. I mean, Google started doing that, but soon enough they didn't want to do it because it was too much responsibility and liability for them, so they backed up. So I guess at some point we need to learn how to share our data and donate our data.
So with our business, because no one's really tracking nutrition right now, we're doing greenfield. So we will track your information, but you own it. It's not part of an EMR. And all the things that you would want out of controlling your information would be there in terms of who does it go to, how much do they see, how long do they get to see it, or do you want to sell it? That would be your option, at least the way in which we're orchestrating our data.
Okay.
And I think we need to figure out ways to anonymize the data as much as possible to give folks the sense of security and privacy. I think folks are very concerned. Youth that we talk to are very worried these days about how their data is used. So we've got to set up systems that make them feel much more comfortable and safe and secure, and that this data is being shared in ways that's not going to divulge their own personal information. So that's also really critical, is designing those systems. And I think I agree with you of trying to find ways to get people to donate their data in ways to support these efforts. I think that is a really helpful, because it gives you the informed consent that you have, that you've actually been providing this level of data.
I mean, your health information are so specific for you. If you give me 5 blood works, it takes me only 26 seconds without name. It only takes me, if I use my algorithm, it takes me 26 seconds to find out who is the owner of this data.
Yeah, I would like to bring the point home, however, that the data has to be of a level of quality that can be conducive to research. So that's your responsibility then.
Absolutely, and we're here to take full responsibility for the heavy burden we bear here. And with the panel coming to an end, it just went by really quickly. The timer's buzzing. I'm getting signs and signals from the surrounding folks. But I'd like to thank every single one of you for this most stimulating conversation to really bring together this community and pave the way for the next virtual healthcare innovations. Thank you so much, gentlemen.
Thank you, Alex.